Okay, so the idea now is to talk about disseminated intravascular coagulation, or DIC. Other names for this is consumption coagulopathy and defibrillation syndrome, which is quite interesting because it describes the pathophysiology of DIC. DIC, which is a situation where the body creates a many clots, and when it's acute and it's rapid, it causes consumption coagulopathy, namely consumption of the coagulation factors, and therefore the patient doesn't have a coagulation factors anymore, and therefore the patient can bleed and bleed severely. So the consumption coagulopathy can describe the pathophysiology, especially of the rapidly evolving DIC, which is the reason why it causes a thrombi for one instance, but also very severe bleeding. Defibrillation syndrome also describes its pathophysiology because the coagulation cascade that occurs in DAC cause consumption of fibrinogen, which converts to fibrin. So the fibrinogen or fibrin levels goes down. So yeah, there is defibrillation. The fibrin levels goes down in DAC, again, especially in acute, rapidly evolving DAC. Okay, so you can understand that we can talk mainly about two types of DAC. The one which is the acute, rapidly evolving DAC, which can be severe and life-threatening, and the other one is the slowly evolving, maybe chronic DAC, which slowly evolves. In the chronic side, in the chronic type, there are more uh, clots creation. Therefore, the patient will present with clots, thromboembolic disease, like DVT, PE. Those are the symptoms and signs we will see in chronic DIC. Whereas in acute DIC, rapidly evolving DIC, we will see thrombosis, but also we will see bleedings because of the consumption of coagulation factors. So here, Merck manual starts with describing the DIC, which it separates from of the acute DIC and the slowly evolving DIC. DIC that evolves slowly cause thrombosis especially, and the rapidly evolving can cause bleedings. Also thrombosis, but bleeding. And the rapidly evolving cause consumption of coagulation factors, consumption of platelets, so thrombocytopenia will be seen, and the D dimer and the fibrin levels will go, the D dimer will go up and the fibrin will go down. The D dimer will go up because it comes from the degradation of the clots that are created in the rapidly evolving DAC. So the D dimer, so there are many clots, so many clots also get degraded as part of the hemostasis of the body. At the time where clots are created, also plasminogen converts to plasmin, which causes degradation of the clots, which elevates the protein that comes from the clots that are degraded, which is the D dimer. And fibrin is used to create those clots, so he is also like the coagulation factors get consumed, so the fibrin levels will go down. Now the treatment. The main treatment of the AC we will see is treatment of the cause. It can be gram-negative infection, it can also be trauma, it can be shock, it can be obstetric complications like abruptio placenta, So we need mainly to treat the cause, which is the main treatment for DIC. Cancer also can cause it, but when there is a very acute settings, we will need to replace what is get consumed. So we can increase the coagulation factors using fresh frozen plasma, which have those coagulation factors, which can increase the fibrinogen levels using cryoprecipitate. And cryoprecipitate is concentration of the coagulation factors, factor 8, also fibrinogen, and 1 millibound factor from frozen plasma. So cryoprecipitate has a high concentration of these components, and especially fibrinogen. And we can replace the platelets using platelets. Okay, and in the chronic type, we can use heparin. The idea to use heparin is to halt the creation of clots and therefore reduce the consumption of coagulation factors and platelets. In the acute DIC, in the rapidly evolving DIC, we won't use heparin because there is bleeding, but in the chronic DIC, we can prevent clots formation using the heparin, and it also will lead to reduce coagulation consumption. So, the etiologies. The etiologies of DAC can be obstetric complications like abrupt sepala that cause rapidly evolving DAC, infection, especially gram-negative organisms. The gram-negative creates endotoxin that cause tissue factor exposure, and therefore the cascade starts. DAC mainly starts with tissue factor exposure. And tissue factor, which is factor 3, is exposed from the endothelium. So when there is damage to vascular endothelium, the tissue factor is exposed, and the extrinsic pathway of coagulation is started. The extrinsic pathway, which is also called a PT pathway. So DIC mainly start from exposure of tissue factor, air, and extrinsic pathway of coagulation. Now, as the coagulation cascade starts, also the fibrinolytic pathway starts with TPA and plasminogen, which convert to plasmin. It's the hemostatic idea. When we are starting coagulation, we also start fibrinolysis, clot degradation. And you can see the fibrinolysis pathway here, mainly converting plasminogen to plasmin to cause fibrin degradation, to degrade the clot. This degradation elevates the D-dimer, and fibrin degradation product is the D-dimer. The D-dimer is part of this. So complication of obstetric like abruptio placenta, infection, especially gram-negative, which expose endotoxin, which cause a tissue factor to be exposed, and the cascade starts. Cancer, APL, acute pulmonary leukemia, pancreatic, stomach, especially adenocarcinomas, can also expose tissue factor. Shock can cause ischemia. Ischemia can cause release of tissue factor. All of this can cause DIC. Less common cause is severe trauma that can cause exposure of DIC, also burns, complication of prostate surgery, prostatic material can be with tissue factor and therefore activate the cascade. Snake venoms which can cause it. Intravascular hemolysis from ABO incompatibility in transfusions, aortic aneurysms, which can cause chronic one. So slowly evolving DIC mainly comes from cancer, aneurysms, and cavernous hemangiomas. Cavernous hemangiomas are let's say a stack of capillaries We won't get into it too much, but cavernous hemangioma is one of them. Cavernous hemangioma can be in many places, like in the brain, and etc. etc. So the pathophysiology of slow DIC is mainly thromboembolic manifestation, like deep venous pulmonary embolism, and severely rapidly evolving, eh, present with both. It present with coagulation and bleeding into organs and microvascular thrombosis because there is consumption coagulopathy. And symptoms: in slowly evolving, we will see thrombosis. In rapidly evolving, we will see bleedings. And diagnosis. So the diagnosis of DIC comes with platelet count, which let's talk firstly about the rapidly evolving. So the platelet count will be low because it is consumed by the clots. Prothrombin time and partial thromboplasmin time, which are the extrinsic and intrinsic pathway respectively, will be high because there is consumption of coagulation factor, and the coagulation time will be increased in the extrinsic pathway, but also in the intrinsic pathway. All of the coagulation factors, all of them will be consumed. Plasma fibrinogen, which will be low because we are using the fibrinogen to become fibrin and build the clot, and plasma D dimer will be high because the clots are degraded and the D dimer is released as fibrinogen degradation product. So low platelets, high PT, high PTT, or prolonged PT, prolonged PTT, low fibrinogen, and high D-dimer is the manifestation, the laboratory manifestation of rapidly evolving DIC, which is in contrast in many different uh, pathologies. Like if you think about TTP and HUS, that can also cause thrombosis or microvascular thrombosis and thrombocytopenia. So it can also cause bleedings, but the PT and PTT will be normal, will not be prolonged in HUS and TTP. Other things like liver disease. Liver disease can cause PT and PTT to be prolonged because most of the coagulation factors, most of them except factor 8, are created by the liver, by the hepatocyte. So evaluating the factor 8 levels can differentiate it between a very severe liver disease and DIC, because in DIC all the coagulation factors are consumed, including factor 8. So in DIC, factor 8 will be low, and in liver disease, it can be quite normal. Um, okay, so what we will see? I mainly talked here about the rapidly evolving. In slowly evolving DIC, the presentation is not quite dramatic. The platelets will be only a little bit low, mild thrombocytopenia. The PT and PTT can be normal or minimally prolonged. Fibrinogen can also be only a little bit reduced or normal, and the plasma D-dimer can be will be increased because of the clots. But wait a second. So, okay, so in chronic DIC, there will be clots. Therefore, the dimer will be high. Remember that we are also use the dimer to evaluate for PE and DVT, which is one of the main markers for evaluation of PE and DVT. Because when there are clots, the dimer will be high. Because when there is clot, there is fibrinolytic pathway. Plasminogen becomes plasmin, and the clots becomes degraded. When it's degraded, the D-dimer will be high. So when there are clots, there is high D-dimer. In chronic DIC, there are mainly clots, therefore there is D-dimer that is high. Okay, so in rapidly evolving, the picture is much more dramatic. Thrombocytopenia will be severe, more severe. PT and PTT will be prolonged. The fibrinogen rapidly will be consumed and gets very low, and the D-dimer will be high. So this is the rapidly evolving DIC. The treatment is mainly treatment of the cause, broad-spectrum antibiotic for gram-negative sepsis, evacuation views in abrupto placenta. If abrupto placenta, there is hematoma and exposure of tissue factor, and with shock, we will give blood volume repletion. If it's effective, the DIC will subside quickly. Okay, and when there is DIC, which is rapidly evolving and there is severe bleeding, we can replace the consumption that are occurring in DIC. For platelets, if platelets are consumed very rapidly, especially if they are less than those numbers, we can give a platelet repletion, platelet replacement. For fibrinogen and factor VIII consumption, we can give cryoprecipitate. Again, cryoprecipitate is we take to create cryoprecipitate, we are taking plasma, and from the plasma take fibrinogen, factor VIII, and von Willebrand factor, and concentrate it to a product named cryoprecipitate. So cryoprecipitate is mainly used for the fibrinogen replacement and factor VIII, but we give fresh foreign plasma to replace all the coagulation factors which are consumed, including antithrombin, protein S, protein C, and etc. etc. Okay, so for slowly evolving DIC, this was for severe bleeding in rapidly evolving DIC. For slowly evolving DIC, we will use mainly a okay, treatment of the cause. If it's cancer, treat the cancer. If it's fetal remnants in the woman, treat this. If it's anything, treat the cause. And if it's prostate cancer, treat the prostate cancer. But heparin can be useful. The reason is because in DAC there are mainly clots, and we want to inhibit the creation of clots. This will inhibit the use of fibrinogen, the use of platelets, and therefore it will increase the fibrinogen, the platelets, and coagulation factors because there are no clots, no use of a coagulation factor, no use of platelets, no use of fibrin, and especially what is important also, no clots, so no thromboembolism disease, no DVT, no PE. So heparin can be useful, but only in slowly evolving DIC. The reason is that in rapidly evolving DIC, there is also bleeding, and heparin as an anticoagulation will cause more severe bleeding. So we will use heparin only in slowly evolving DIC and not in the rapidly evolving DIC, which can cause severe bleeding. Okay, so this was about DIC, the slowly evolving and the rapidly evolving disseminated intravascular coagulation. Thank you very much. This was from Make Manual Professional Edition. If there are any correction, please correct me, and that's it.